Today, I'm going to talk about concept, I should say the Sipaka solution on how to boost the growth of rural hospitals through ICUs. We all know that in India, there are approximately 40,000 registered hospitals as on date. And every year, at least 1,000 hospitals are being built, at least. And I must say that at least 70% of them are either in rural areas or in suburbs of cities. My definition of rural area as far as hospitals are concerned, anything that is not in tier 1 and tier 2 city is a rural area. Similarly, anything that is in the suburbs of the city is also rural area because they are small hospitals and they depend predominantly on the patients coming from surrounding villages or rural areas. You don't get a really corporate patients or extremely rich creamy layer of patients to these hospitals, right? They go to corporate hospitals. So these hospitals, which are owned by doctors, at least 90% of the rural hospitals are owned by doctors themselves, where doctors are working as doctors. They being owners, they work as doctors also, like employees inside the hospital, and then they slowly try to develop and grow the hospital. Many times I know that some people would have taken to, from the time of beginning the hospital, to just add 20 beds, they take 10 years. Like you start a hospital with 40 beds, and then for it to become 60 beds or 80 beds, it takes 20 years. Many times I've seen that. And many places, there are even generations of hospitals which are still the same size, same services. And they don't even bother to grow to the next level. Okay, these were the people who started hospitals before pre 2000. Okay, and today technology has changed. We have changed. The way the business or the healthcare industry runs has pretty well changed. So this talk is for those who are inclined to grow their hospitals to the next level. Maybe just let us say that in the next 2 to 3 years' time, I want to double my turnover, for example. So to understand that, we need to understand what is happening today, how the industry is going, and then let us examine the steps how we can go forward. So let us dissect first, the way how we are actually running, and then slowly you will move to the next level. So what does it take for a small hospital to grow 2x turnover? So what are the challenges and what are the solutions? And then running ICU, what are the odds of success? When can the project fail? Many people would have tried ICUs, and then when the doctors or the nurses left, they would have given up. How this model works, okay? How Sipaka impacts the ICU quality and growth of the hospital. So what is the model that we offer? So as I told you just now that this talk is for small and medium-sized hospitals. Uh, by definition, a medium-sized hospital is something which is less than 100 bedded, and these are anything less than 100 bedded hospital which is situated in rural areas or in suburbs. As I said, usually they are 20 to 60 bedded. Normally, these hospitals will have a varying occupancy of 25 to 75%. In seasons, good seasons, like we all know, in the rainy seasons, winter and rainy seasons is where you get more occupancy. It may go up to 75%, and remaining times maybe 20 to 25% is the occupancy. Usually, the owner and spouse are the two specialist doctors, ortho and gynec, surgery and gynec, physician gynec, or any of the the related combinations. They might have some 5 to 10 visiting consultants, maybe coming from the nearby city once a week and going back, or who are settled in the local area, a surgeon, physician, a pediatrician, who is coming and visiting the hospitals either daily basis or a weekly basis. And these hospitals usually have some resident doctors who are MBBS doctors, but in many places, these are actually non-allopathic doctors also are working as the duty doctors over there. Typically, the overall outpatient load of these hospitals can be between 100 to 300 per day, all departments put together. And there are some hospitals where they do even 3 to 4 surgeries a day. Some hospitals max one surgery a day. When you do this, the average turnover can vary anywhere between 10 lakhs per month to 50 lakhs per month with this scenario. Usually, these people make a net profit of, let us say, 5 to 10%. You call it PAT, no? Profit after tax, if at all you pay tax. So this is after salaries, after your EMI, after the payments to all the consultation fees to doctors, all these things. Question is, people are very happy. Many times they tell that, sir, I saved some out of when we have 30 lakhs turnover, we save at least 10 to 12 lakhs, or even 15 lakhs they save. But at what cost? You are also working like a doctor, no? There. What about your salary? What about your working, the compensation for you for working as an employee? You are also working, no? You are not enjoying. You are working every day 10 to 12 hours. So what about that? So when you account for all these things, you have to calculate what is your actual net profit. And these people, some people, they go brick by brick. That's called, brick and mortar model, where you first set up OPD, then add 5 beds, then add another 5 beds. That is one model. In the last 2 3 decades, people have become little bit faster. They just take loan because banks are giving good amounts of loans. They construct 20 to 30 bedded hospital and then start running. Several times, they have EMIs and payments to be made. The operational break even takes 3 to 5 years time. As I told you, when the owner himself is working at least 12 hours a day, 6 to 7 days a week, you have to actually take that, deduct your salary, before you think what is the profit. If your outpatient fees is 100 rupees or 200 rupees, and whatever the every day whenever patient comes, he definitely gets some tests and then buys some medicines, approximately, let us say, 1,000 rupees. And if you are seeing 100 patients with 1,000 per day total bill, your turnover is 1 lakh per day. Okay, so that's a turnover, not profit, because lab and pharmacy, the overall turnover cannot be taken as profit. So this is how you come to an average turnover of 30 to 50 lakhs, if at all you get this. After your payments and your discounts, everything, and then your deductions in payables, everything is gone. This is how a hospital runs. If you, whoever is listening to this talk, okay, if you fit into this model, I think we have some solution for you to grow to the next level. So in the next 45 minutes to 1 hour time, I'm going to explain several aspects of how one can grow. Okay. Now, so as I have been telling that, there cannot be a cakewalk for everyone. Until this, it's a cakewalk. Okay. But beyond this is a difficulty for people. That is where they get stuck. I'll just take you through a small case study where a small town, which is surrounded by 20 villages, small villages with around 5 to 10,000 population of each village. So that takes to a total serving population of 2 to 3 lakhs approximately. And we have an elderly farmer from nearby village with all comorbids. Okay, diabetes, hypertension, cardiac, COPD, everything comes with an infection, let us say 5 days fever, shortness of breath. He came to the hospital. Typically, the hospitals which I told will have maybe 2 to 5 bedded ICUs. Everybody puts a board that I do 24 hours emergency and ICU services. Now, this owner is a doctor who is a physician, and but there is no dedicated ICU team, but he is operating on his own. He has got on-call cardiology, nephrology, pulmonology available. He admitted the patient in emergency, shifted to his ICU, but the vitals are not that favorable. Heart rate is high, his breathing hard, saturation down, high temperatures, sugars are high. Even ECG is showing some strain, bilateral V's, and the patient has some metabolic acidosis. You have given basic medicines like para, nebulization, insulin, IVF, all other things. X-ray showed bilateral patches, whether it is pneumonia or failure or combination. You don't know, but patient certainly did not improve after 2 hours. He is deteriorating. What do? We usually refer to higher center, right? So nearby city, which is around 50 kilometers away, it takes 2 hours to go. Patient was received in the city corporate hospital. He was put on ventilator. So 20 days of ICU stay and 15 days of ward care. And total bill was 20 lakhs. Of course, family also had to spend some more amount, on other overheads. Naturally, for a farmer, 25 lakhs is a bad news. So he had to sell his house. Another example, same place, an elderly lady with all comorbids like diabetes, hypertension, cardiac, COPD, obesity. She comes with umbilical hernia. She went to the locally famous surgeon. Surgeon is willing to operate, but anesthetist said, look, we can operate, but post-operatively, this patient might require the ICU care. If something goes wrong, she might land up on ventilator also, and we may not manage her here, and you may have to refer out at that point of time. Which surgeon takes the risk, or the hospital takes the risk when you have to refer post-operatively to some other place with a complication? So, since there is no good ICU, they refer to higher center, again the same place. Patient was received, surgery was done under high risk consent. Patient was there in ICU for 2 days post-operatively and then discharged. Total bill was 3 lakhs. Of course, they normally surgeon charges good amount of fees, no, in the corporate hospitals. The surgeon in the city, the irony is that the city surgeon is actually 10 years junior to the family surgeon in the town, okay, who referred the patient. The surgeon who is in the rural area can actually do the surgery well, but because he has no other support systems, he had to refer the patient. And a junior surgeon, junior to him, surgeon who is junior to him, could operate the patient comfortably. And patient, because the system was in place, patient was taken care of. Now what happened? Patient continued her care, future care with the city surgeon. Naturally, whoever does surgery and saves the person, naturally they go there, right? Now, if the surgery had been done in the current town, it would have costed only half or less than that to the patient. Also, the patient would have been remained here. Also, patient would have saved some amount, isn't it? So that is the irony. One of the two examples, I wanted to give that what happens in rural health sector. I hope all of you know this person called Dale Carnegie, very famous man who wrote this book called How to Win Friends and Influence People. One of the foremost business people who brought this concept of data. So he said that, I may be wrong frequently. Yes, I am wrong frequently, but let us examine the facts. Facts means data. So my question to you is, in your place, not just your hospital, in your place, every month, how many medical problems are being referred to cities? How many surgeries are not taken up locally, even though the surgeon is capable, but because the patient is not medically fit? How many people you are referring out? What is the cumulative loss of practice? What is the financial burden on the patients and their families? Forget about our loss, but patients and their families, how much are they spending more? How many lives are being lost because of lack of treatment during the golden hour in emergency? And finally, what is the burden of worsened morbidity from such delays? Let us say you referred a patient was received in the hospital after 2 hours. But are you aware that whatever the spread or worsening of the sickness during that delay of treatment will add to the time for recovery? Which means in half an hour, if I could start treatment and properly treat the patient, and the patient needs 10 days of care, after 2 hours, the patient receives treatment. Don't you think patient takes more time to recover because organ damage has been more during that delay? So if any single hospital in the town had a good ICU, and if all the practicing physicians and surgeons use that ICU with harmony, 50 to 80% of patients that were being referred previously can be managed locally. So this is the fact or the data based on which one has to think that by having ICU and by improving the services in my hospital, it is not that I just survive or I just grow, but actually I am giving a very reasonable social impact and financial impact to all the healthcare providers, as well as to all the patients and their families in my locality. So if you look at the healthcare industry in India, this is a good news for all of us. Whoever is there in healthcare industry, it need not be just doctors, the owners of the hospitals, paramedical people, pharmacy, lab, anything that is radiology, everything that is related to healthcare industry. The statistics, what do they say? You know, Healthcare is the third largest growth segment in India. That is number one. Number two, if you look at the healthcare industry in India, you see here in the US dollars, from when in 2008 it was 50 billion dollars, it is steeply rising to touch $250 billion by 2020. It is said that you see the rise in the curve. It has been extrapolated that this rise will keep on going until 2050. Maybe after that, it might touch a plateau, which means for the next 30 years, for whoever has been there in the healthcare industry, for them, the industry is booming and growing. COVID has actually proved the same fact, no, for all of us. On top of it, what is happening in our country? There is growing middle class. There is growing and aging of population. Okay, so there is growing of urbanization of people. When you have elderly population, the number is growing. You have more lifestyle diseases, and also pollution is growing right now, which results in more chronic diseases, which results in more organ failures, which needs more ICUs. So the it is not just that healthcare is thriving in India. Also, the base feeding of healthcare industry is also growing. Similarly, basic need of ICU services is also growing in the country. Now, this is the current statistics. In 2017, the data shows that the per 1 lakh 100,000 population per country, how many ICU beds are there, critical care beds per 1 lakh population? When United States has 30 plus beds per 1 lakh population, India doesn't have even 3 beds per 1 lakh population. What is the growth of COVID? COVID centers, COVID ICUs have been formed, but temporarily formed by most of the government bodies, right? Even in this 2.3 per 1 lakh ICU beds, 80% are actually in metropolitan cities only. These are total number of beds per 1 lakh population. You know very well, we all know very well that reasonable ICU beds are there currently available only in metropolitan cities. Maybe in the metros, tier 1, tier 2, maybe tier 3 cities. Beyond that, we all know that, no? At many of the district level hospitals and none of the taluk level hospitals, at least many of the places, you don't have reasonably good ICU beds. That is the data speaks that. As on 2021, last year, India touched 130 plus crore population, where you have 70% of Indians, they reside in rural areas and suburbs of cities. 70% of the specialist doctors, they are only in cities. So what is happening? You have all the critical care uh, requirements, the people who require critical care from the villages, okay? They come to taluk or district hospitals, isn't it? First level is there. And if you, they are the first line platforms, for treatment. Now from village, they go to taluk level or district level places. If they don't have proper ICUs, especially in the suburbs, you have to refer no to other hospitals, corporate hospitals. If you are in a city suburbs and you don't have ICU, you have to refer the patient to in the city to corporate hospital. Or if you are in a tier 3 town or maybe in a taluk place, you don't have ICU, you have to send the patient to either city or tier 2 city, either to district headquarters or tier 2 city where you have ICU. So that adds, number one, loss of practice for doctors. Number two, adds burden to the patient. That is what is happening. Now, as I told you, we are going to dissect several aspects and then understand why the problem. If you look at the breakup of whole hospital sector, you see you have pharma, you have equipments, you have lab, that is diagnostics, insurance, you have digitalization. These are the part and parcel of whole gamut of healthcare, right? If you take the hospital, your equipments and including beds, cots, everything is one side, and then your lab and pharmacy on the other side. Remaining 70% is about hospitals running the services, healthcare services, which means through manpower. This constitutes doctors, entire manpower, medical, medical and paramedical manpower. So what is the problem here? You have standardization across these small areas. For example, you take paracetamol. You may call any of the trade name for that. I don't want to take the trade names here. Any trade name, but paracetamol works the same in Kanyakumari, Kashmir, in Gujarat, and Arunachal Pradesh. Everywhere you go, whether you are in a most rural area or the city in the middle of Delhi or Chennai, it works the same. You take monitor, it measures the same everywhere. You take cot, it is the same. You take CT scan, you take MRI, you take ultrasound, echo, everything works the same. Similarly, LFT, it measures the same, no? Whether you take blood test and then send for LFT, any lab for that matter, any lab machine, it only shows bilirubin, SGOT, SGPT, all these things, right? Urea creatinine only comes in, in the renal function test, right? Which means by giving money and getting the service or the equipment or whatever the item, you get the same service across the country. That is what is known as standardization. So these services, 30% of the healthcare services have been standardized, whereas remaining 70% of the healthcare services have not been standardized. Why? Because they depend on manpower. That is the reason why you have one leading doctor, another person is not a leading doctor. People go to only to leading doctors or known doctors or famous doctors. If you have a hospital, last 10 years, 15 years, you have been the gynecologist, you have been the surgeon, you have been the physician, you have been the cardiologist, you have been the nephrologist, neurologist, orthopedician, whoever it is, diabetologist, because you have proved yourself. So people come to you. Suppose if you want to set up a department, another department, let us say you want to set up, for example, a nephrology department. No, dialysis machine is easy to buy. RO water is easy to get. Dialysis is easy, but the nephrologist or the system of people you have to standardize, right? You want cardiology department. It is easy to buy. You pay money, you will get the cath lab machine. But do you get the proper team, cardiac team for that? Now, for people where you require only one doctor to set up a department, if the story is like that, if you want to set up ICU or emergency department, it's the round the clock department. Now, if you get two doctors or three doctors, how are you to be sure that the quality of care given by them can be the same? Similarly, you get a team of nurses, let us say 6 nurses, 8 nurses, 10 nurses. How are you to be sure that they deliver the same type of services? Okay, you set up the team today. Okay, after 1 year of war struggle, you could set up a team. How are you to be sure that the team will continue the same? Tomorrow, people leave the organization, then the whole entire teamwork is gone, no? So that is why, except the chains of corporate hospitals in cities, all the small and medium-sized hospitals in small towns and suburb areas, when they are headed by doctors, only those departments are okay. But when it comes to setting up other departments, there is problem of standardization. There is problem of defining business models. There is problem of defining the quality delivery, systems there. There is problem of setting up policies to deliver quality and then define a business model there. So this is the reason why people struggle to grow, to set up more and more departments in the hospital. They give up. They think that, okay, it's difficult for me to get people, so I am like this. This is the main reason why we don't grow. The hospitals do not grow to the next level. Not because you don't have money. There are banks to fund us left, right, center. There are all these 30% pharma, equipment, diagnostics, and other things, digitalization, everything you can buy. Just give money, you can buy. You take loan, give money, buy. You have people there in and around who are waiting for services to get. What is your problem? To set up and establish other departments is the problem, because they fall under this red category where they are human dependent. They need policies, protocols, and then proper supervision. And you cannot spare your time because you are already drowned as a doctor in your OPD, IP, and maybe so if you are a surgeon in surgeries, administration of the hospital, your 24 hours is gone already. So who will sit on this? So that is the main problem why small and medium-sized hospitals, they face challenges to grow to the next level. If they are fortunate enough to get certain people who can set up the departments, that is when they grow. Now that is where Sipaka came out with a solution where what we do is we want to make the best critical care available to patients across hospitals of different levels by making collaborations. Simple. So, how do we make best critical care available across all the hospitals? Because we standardized it. We know how to set up and manage ICUs. We provide multidisciplinary ICU teams, both medical and paramedical. We have different levels of supervising teams, cluster and regional level teams to ensure quality of training and execution and patient care, and then policies and processes. We also support in marketing and business development of the private hospitals, ultimately providing international standards of ICU treatment for the middle class. That is how it works. So how do you set up an ICU? There are steps in setting up an ICU. First of all, you have to give experienced ICU team. All the team, not just doctors. You see, by just bringing a doctor, it doesn't work. A doctor may be good, but he needs to be a good administrator also, no? And round the clock, he has to take care of the both the things. And he needs to be a HR. Do you think he's a HR person also to bring nurses? And then do you think he's a training person also to train nurses? And then ensuring the quality, all these works where how can one person do? So you need a system for that. So you have to give ICU team. Then you have to ensure round the clock, uninterrupted, same quality of services, not just daytime. Many hospitals they have consultant coming and making rounds and going away. And rest of the times you on call, the person may come. But who will take care of them during nights if the patient crashes? How can you get a correct ICU by that? And then get the super specialty backup team. If you have super specialists or other specialists available locally, very good. If they're not available, when you have a standardized structure here below, then you can take telemedicine opinion from them, not making tele ICU. Suppose your entire structure is only tele ICU, then you are gone. Who will structurize? Okay, people can give opinions and then give the care related pathways to people. The problem here is not guidance. Problem here is execution. Problem in rural places is not guidance. If I sit in metro city and give guidance to doctors in the rural area, who is going to execute it? Who is going to supervise it? Now, suppose you have a team there on the spot who knows everything and who is already providing uninterrupted services. Then you can always have the specialist coming and going, giving inputs on their own departments. If I have, let us say, a patient with MI, I thrombolized the patient in the ICU. I don't need cardiologist for that. If the patient is ongoing, let us say chest pain, and then if the cardiologist is not available directly, I contact him on tele, and then if he says that yes, this needs, let us say, cath, then I refer the patient to or shift the patient to another place where I can take primary angioplasty. Otherwise, I don't have to refer the patient out. No. Similarly, gastro, pulmo, for that matter, I just need an opinion from the pulmonologist saying, okay, boss, let us start this antibiotic. Otherwise, all the ABG, all the acid-base balance, all the ventilation, airway breathing circulation, basic management of ICU, nutrition, if my team here can do all these things, why should I refer a patient at all? So I just need support teams, that's all. Now, once you do that, then set up the international protocols, not just inpatient care. ICU is not just a patient care. You need to have protocols. You need to have timelines. When should I, what is my needle time, door to needle time for antibiotic for that matter of fact, IV fluid resuscitation for that matter of fact. How can I ensure that there are no bed sores or the complications developing for the patient? All these things, they depend on processes and protocols. After that, there should be supervision because you give book of protocols, it's not going to happen. No, you have to ensure that all these people follow these things. If somebody is not following, you have to remove that person or correct the person. So that supervision is what is required. When you ensure all these things, then you become a center of excellence in ICU. It's a process. To begin with, you start with this. Over a period of 2 to 3 years time, you reach here. That is when hospital will become a center of excellence. From being a referring hospital, how can it become a referral hospital for others? This is how it becomes. Once you become this, even the super specialty departments, they come to us saying, yes, I have no problem right now to keep my patients. And people will come to us. So this is the foundation for growth. So how do we standardize? You standardize, first of all, the infrastructure. I should have, if I am putting 5-bedded ICU, what is my list? If I am putting 10-bedded ICU, what is my list? Across all hospitals, I need these things. What are my teams? How am I going to engage people here? What are their qualifications? What are their experience levels? How am I going to take them? Who do I need in the first year? And then after third year, who do I need? Based on the number of patients, I should have processes defined and then administration process. How am I going to manage each one of the patient? And then, yes, not just documentation, but the working model has to be standardized. And how am I going to do marketing or branding or business development for my rural area in that place? When you have everything standardized, that will become a model. And that model, when implemented properly, will succeed. You see, when you take metro cities where you have big mega hospital brands, each ICU normally, don't you think they cost at least 50 to 60,000 a day? And including pharma, lab, and other things, if the patient is on CRRT, so other organ supports, it touches almost a lakh a day, isn't it? Similarly, you go to the second level cities where, something like Pune or Coimbatore in Tamil Nadu or Vijayawada in Andhra Pradesh, something like that, where The second level hospitals, they are also metro hospitals, but they charge approximately 25 to 30,000 a day normally, and total bill will become 50 to 60,000 a day. And whereas some of our hospitals, for example, where we are in collaboration with Sipaka in rural areas, in taluk areas, we charge 5 to 10,000 a day. So the total cost will not be 10 to 25, 20,000 a day, which is 25% of the big corporate hospitals, and sometimes it is 10% of the metropolitan top class hospitals. So the people, the patients need not travel to such an extent to get the services. You are actually making it accessible and also affordable. For example, what are the patients that you can manage when you have a multidisciplinary ICU? All the patients. When they have problems, you can manage them. Only probably I would like to give you a few examples. Let us say you don't have a neurosurgeon, there is a midline shift after trauma. Maybe that time you may have to transport faster. You have thrombolized the patient, but there is ongoing ischemia. You need primary, PCI. Maybe you have to transport at that level. You have a polytrauma where you need several surgeons, ortho department, plastic surgery department, cardiac department, gastroenterology department. There is liver laceration, there is lung contusion, there is, head injury. You need neurosurgeon. Then yes, maybe that's not the place where you can manage, in a rural area, in a taluk hospital ICU, where there is a vessel cut, for example, artery cut. You need a vascular surgeon. You don't have. So except the surgical emergencies, okay, or procedural emergencies, rest all the 95% of the patients you can manage. Cardiothoracic surgery, 95% of the times it is an elective surgery. So you stabilize, and then you can, even if you think you need CABG, CABG is not an emergency, at least most of the times. So all the other problems like diabetology, endocrinology, ENT problems, gastro problems, surgical problems, medical problems, obs-gynec problems, oncology problems, they are all medical problems most of the times. If I have a general surgeon available in my place to take care of basic surgical procedures and a general physician at least on call, my ICU is enough. Okay, if I don't have a general surgeon, I don't take surgical problems where I need surgical, complicated surgical procedures. Otherwise, all the other patients can be managed in an ICU. 90 to 95% of the medical problems and at least 60 to 80% of the surgical problems can be managed in a multidisciplinary ICU, at least to stabilize. Then you either call the surgeon here or send the patient there. Many times after the second and third year, in our ICUs, we have surgeons coming into our place to perform the elective procedures and non-emergency procedures. Who can admit the patients? So the doctors of the hospital, yes, they can admit, but we don't stop with that. We also open the ICU for outside doctors to admit patients. That is where we want to provide solution to the entire region, not just the hospital. This model is answerable to even to the system. Okay, you are a hospital owner. You are referring out, for example, one or two patients every day. But surrounding your place, there may be 4 or 5 physicians or practitioners who will be also referring maybe one or two patients every week. And why do they refer? Why should they refer to other places? Because they don't have an ICU. In that case, let them connected with this ICU. We will manage their patients also. You will be benefited as the owner of the hospital. They also will be benefited because they don't need to refer the patients out. And most importantly, the patients will get benefited because they now the ICU has become accessible for them within half an hour of reach. And it is affordable right now because they don't need to spend that much amount. At least 50% of the bill they can save, right? So what is the social impact having an ICU in a rural place? This is a very, very important slide. I need all of you to kindly mull over this. Suppose you are in a taluk level or a district level place, or even in a suburb of a city. Think over this. If you are referring out a patient from your place, normally that patient spends 15 to 20,000 on travel, no? If it is 1 or 2 hours journey. Okay, you are in a suburb place where patient just needs to go 5 kilometers away to a city hospital, then it doesn't matter. But definitely in a city corporate hospital compared to your place, like if you don't have an ICU, they may have to spend 25 to 30,000 rupees a day extra for the care. Now, average stay will be 5 to 7 days in ICU, and the total extra burden of such for such care in on the patient will be, so per day 25 to 30,000 multiplied by 5 to 7 days will be approximately 1.5 to 2 lakhs per patient. Now let us assume that from your place, not just your hospital, from your place, maybe one or two patients every day are going to a nearby city, which means 30 to 60 patients per month. Do you know a cumulative financial burden on the community, on your community, is approximately 1 crore every month? By you putting an ICU and upgrading your hospital, you actually save this money. Even let us say there are places where you may not agree with me with this number. These are all our research data points. If you say, oh, no, no, only 15 patients we refer, okay, then in that case, it's definitely 30 to 50 lakhs from the community. It is being lost. By you keeping an ICU in your place, by collaborating with nearby people, you actually save this money from those patients, from those people. So what next? So what to do to grow further? So, so what is the time and efforts taken to double the turnover? So why small hospitals struggle to grow beyond a point where, whereas in the same time, city hospitals grow very far, very fast. They grow very fast. So if you ask me, based on the data that I have showed you, the problems of standardization, problems of establishing departments, problems of thinking, problems of lack of help because of you are there in rural places and your community, what is the problem that they are facing? So this image is, a very good resemblance of a small hospital owner. His problem is, if you ask me to put it in single point, because he is trying to do everything by himself. He or she or they are trying to do everything by themselves. That is why they have this struggle. Let us say, what are the solutions? I told you we have dissected so far. We found out what has been happening so far in rural places. Most of the things you also know. I am not telling anything new here. I'm only reiterating the facts. Now, having gone through all these things, there are two very good possibilities to grow the revenue. Very good possibility. They are straightforward answers. As a hospital, if I want to grow, what are the options to me? Number one, I have to increase the number of customers. For any company, this is not the same thing. Even you take let us say a shoe shop which sells chappals and shoes. How do they increase their monthly revenue? You need more customers to come and buy. That's all, no? And number two, if you have the same number of people, you increase the revenue per person. Each person buying 1,000 rupees. Now, the same number of people, they are buying for 2,000 rupees. Now, your revenue doubles, no? So, either you have to increase the number of people coming to you, or you have to increase the spending of these people on in the hospital. I'm not saying you increase the cost, but increase the services. Now, how do you do? Number one, to increase the number of customers for your hospital. This is a very important slide. It opens up several thinking processes for a hospital owner. How can I get more number of people? Because I have only a small town. My town is only 70,000 or 1 lakh population or 50,000 population. How can I increase my number of people coming to me? You can't increase the population, definitely. Just like that, your town cannot become double the number of population, but you can increase coverage of population. How do you do that? By increasing the services that are not available in 100 kilometers radius or 50-kilometer radius. Let us say you are in a town where The town has got only 10-kilometer radius and you are giving some service. The same service, 4 or 5 people are giving in the town. Then you are one among them. Think that you start a service for these people which is not available in 30-kilometer radius. Then your covering population has naturally increased. So from 1 lakh or 3 lakhs, now I've increased to 5 lakhs or 10 lakhs. That is one thing. Second thing, give more services. Even to the same number of people, you add the service so that that service is not available in the same place. So that is how you increase the number of customers. They will come to you. Am I making sense here? Okay, second point. How do you increase revenue per person? How do people come to you without asking a question? They pay and go. Simple example. Do you bargain when you go to a mall? Do you bargain when you go to a cinema hall? Because they are fixed. Whereas you go to a roadside vendor, you bargain. Even if he says this particular thing costs 100 rupees, you can actually pay 100 rupees. Don't we bargain? Give me for 80 rupees, 90 rupees. Why? Because you perceive that that particular thing, item's value is less. So for people coming to you, for them to perceive that your value is more, you need to have branding in place. Otherwise, when you are not branded, why branded things, branded shirts, branded pens, branded shoes, branded cars are more costlier? Because they are branded. So, number one, you increase services so that each person spends more money, or increase covering population where more people will come, or increase branding so that people will not question you on your services or your quality of services, or they don't bargain with you for whatever you are giving and ask for discounts. So that is where Sipaka adds value by increasing the covering population. You don't have ICU in your place, at least a good level ICU. By giving it, you cover more population, number one. So more people will be attracted. Number two, you are adding a service. ICU is a service. You are adding services now to people to come, and you are adding branding. So by collaborating with India's largest rural ICU care provider, it's a branding for the hospital. Now, the owner can proudly say that it is not just that I started an ICU or I employed some 4 or 5 doctors. Then it becomes my own production. By joining hands with a national level, giant, now it's a brand value for me. For my people, I am giving you a national level services, not just my level service. That's a brand. Why do you get a US or UK trained doctor to come and give service? Why do you advertise? Don't you advertise when you get people, doctors coming to you from city hospitals? They say that, such and such hospital doctor is with me, or doctor from AIMS, doctor from PGA, doctor from US, doctor from UK is with me. That's what is called branding. Saying that such people are with me is a branding. Now, a national level number one rural ICU care provider is with me. So, branding. So, that improves number one covering population, it increases your service, and it increases perception of people as branding. So, this is how you start getting help. So far, you are alone, to improve grow your business. Now, there is somebody else also working for you to grow your business, grow your hospital. This is how the equation works. Normally, this is how the average, ICU in many of the small hospitals. If you ask me, at least 80% of the hospitals which claim to be having 24 into 7 services, their ICUs are like this, 2 to 4 beds. How on earth a person can get a financial viability on this? Now, you can't definitely get 4 bed, 5 beds, a full team, no? When you don't have full team, how can you provide quality services? And when you can't provide quality services, you settle with only reasonably stable patients, and you start referring out all the sick patients, reasonably unstable patients. So you are losing revenue. For example, if a casualty, you have a practice where casualty admissions are 5 to 10 per day, and then ICU admissions are 1 to 4 per week, but you are referring out 1 to 4 per week. This is how a normal uh, I should say the calculation works for small hospitals. Now, each patient who is referred out to nearby city pays a bill of 2 to 5 lakhs in those places, isn't it? If you have retained these people in your place and charge only half of it, one fourth of it for that matter, your whole bill will be only 50,000 rupees. Okay, max 1 lakh or 50,000 rupees in the current hospitals. Similarly, if the high risk surgeries that are not taken up and referred to higher centers for surgery, and if you say that, I not only me, not just my hospitals, but by collaborating with nearby people, I make at least 10 surgeries in my OT, just adding them, okay? And each surgery a bill of, let us say, 50,000 rupees. Is it not an additional revenue for the hospital? So by just increasing 20 ICU admissions a month, and just by increasing 10 high risk surgeries, either you are previously referring, okay, which makes a revenue loss of 30 to 40 lakhs a month. And if you retain them, will reverse this. Even if I say it works only with a probability of 50% less, 50% probability, still it adds to 50% revenue of your turnover, monthly turnover. These are the numbers, these are the statistics. I told you already. We are going to dissect down and we are going to talk only data and statistics and values. So now you please calculate that, by not having an ICU, what am I actually losing and what am I taxing my people with? My colleagues, my other healthcare professionals, so-called competitors. You know what? We are all competing with the small shops. It is like small, these vegetable shops or the shops that sell the, cooking, um, what do you call them? The utensils, small general shops. It is like this. We are all like that in small places. How do you take this, the competition to the next level? Just transcend the competition. Simple answer. The moment you become a supermarket, everything else will become a redundant. Nobody can compete with you. Simple. How long will you be competing with that, with those people at the same level? It is said that eagle, how does eagle take the war with snake? When if the snake is fighting with eagle, eagle does only simple thing. It just holds the snake and then flies. The moment it flies, snake has lost its territory. The battle has gone into the next level. Sky is not the territory of the snake, no. Eagle can be on the land, also in the sky, but snake can only be in the land. Now, when eagle catches the snake and then flies into the sky, now snake loses the battle automatically. In the same way, all these people who are currently the competitors, in and around some 10 to 15 doctors who are also seeing the same services like you, the moment you put an ICU, they become actually your customers. They start utilizing your services. They also start because you are becoming somebody who is beneficial to them also. Then you are actually including them into your domain, and that is how it works. This data again came from 2017 data, and the WHO has given this data saying what is the cost of critical care in India? Average, see, this is only an average cost of treatment. If it is a cardiovascular disease, approximately 3 to 4 lakhs. But if it is a lung problem and needs ventilation, please see here, 20 lakhs. Of course, cancer care, other things. You just see, for you to give cardiovascular care, you need to have cath lab. For you to give cancer care, you need to have radiation department oncologist. For you to treat liver diseases, I'm not talking about liver transplants, general liver diseases, a good ICU is enough. Maybe if you don't have a gastroenterologist, a good trained physician is enough. Now, kidney diseases, of course, you need to have dialysis department. But combine these three problems: cancer-related critical care, liver-related critical care, lung-related critical care. A good ICU can cover. A good ICU can cover. Now, I want to draw your attention to this. If a patient needs ventilation, is spending 20 lakhs on critical care, you know, An average turnover of a small hospital, I told you, will be anywhere between 40 to 50 lakhs a month. Whereas in city hospitals, two ventilator patients are paying this amount. That is the value of ICU. In my previous slides, I explained. I took each patient's care in city hospital. I said only 5 lakhs. Treatment cost, I took only 5 lakhs in all my comparison slides. The data from WHO says it is actually average cost is 20 lakhs. So I have taken the average calculations at 25% rate. And even I have discounted 50% out of it, which means at 10 to 20% of probability of working model for you in the hospital by having an ICU, you have 5 times chance of doubling your turnover in the next 2 to 3 years time just by having a good ICU in your place. That is the probability of success or growth of a hospital, you know, of the hospital in rural areas or suburbs if you don't have a good ICU. Even if you charge, that's what I said, 25% in your rural hospital, 10 such patients will give you double the turnover. 10 admissions. I am asking whether you are referring out or not immaterial. Of course, you should have that data in place. By just joining hands with such people, 4 5 surrounding people, joining hands, not competing, joining hands will solve your problem altogether. You are there already at the double with double the turnover. So, so that is what I spoke about. So this is where I again ask a question: running ICU, what are the odds of success, and when can the project fail? Definitely, if you run ICU like this, it will fail. It's. I don't call it an ICU at all. This is not an ICU for that matter of fact. If you call this as an ICU, then it is going to fail. But if you run your ICU properly, a tertiary level care, multidisciplinary ICU, something like this, okay, where you ventilate a patient. This is one of our taluk hospitals where we are ventilating a patient properly. Okay, this is one of our hospitals in suburbs. Okay, we are ventilating a patient properly. If I run ICU like this, there is 0% of failure. But if I run ICU like this, there is 0% of success. So you please define your odds. First of all, before you think of failure or success, first of all you define what is ICU. Then you take it forward to go to the next level. I have already explained this in my previous slides that in India has 40 plus thousand hospitals, private hospitals. Google data says this, out of which 5,000 are in cities. They are all top hospitals and they have 60,000 ICU beds. So all these hospitals, they have very good ICUs. They are all city hospitals. That is why they are successful. They are growing. They are adding departments because the specialists who are coming there, they don't worry about difficult patients or critical patients because ICU handles that. Whereas in small hospitals, even if you want to bring a specialist, he will ask one question: I can't handle critical patients here because you don't have ICU. Now, 30,000 of these hospitals are in suburbs and rural areas, which do not have ICUs. And 50% of Indians have to travel more than 2 hours to get to a tertiary level ICU. These are all facts. 50% Indians have to travel more than 2 hours. So, this is again one of our ICUs in a taluk area. If you want a sure success, you have to have some ICU, something like this, ICU working something like this. So I'm happy to share with you that Sipaka has been now regarded as India's leading rural ICU care provider. This was when we had 5 states in 2021. Today we are covering 10 states. So where we have been, identified in Indo-Arab Leadership Summit as best innovative healthcare delivery system. Innovative. The methodology of Sipaka, the way we collaborate, the way we work, has been recognized already in the international platform as innovative. Again, best ICU services in rural India, best COVID ICU care provider, and then most trusted multidisciplinary ICU care provider in rural India. And to my heart, this is very close, the most socially responsible organization at the national level. Why? Because what we are doing, we are impacting the revenue, the financial model of people, the financial, what should I say, reserves of people. We are impacting that at the rural areas for people. We are preventing them from paying, 5 times more money in the city level, the corporate hospitals by establishing ICUs in rural areas. So now I'm going to talk deep about the model. So far, we have examined the data, facts, the problems, and then the possible solutions. So the putting an ICU, starting an ICU, a good quality ICU, how it solves the problem of not only the hospital but also to the entire healthcare ecosystem. And I said how Sipaka can help. Now I'm going to talk very deep about the partnering or the partnership with Sipaka, the real Sipaka model, the deeper aspects of the model, including the financials, how it is going to work for the growth of the hospital is what I'm going to talk right now. We work on three principles. These are the three principles which have been actually taken as a reference from several big and known organizations, like UNESCO, WHO, for a sustainable growth. So we also, for this partnership, we depend on three very, very important principles. Number one, the principle of equitable partnerships. Number two, the principle of sustainable development. Number three, the principle of sharing economy. Although in the previous slides, I explained about how this works in a very superficial manner, we are going to now go dwell deep into each one of these. Now, what is the principle of equitable partnership? So we said the between Sipaka and the partnering hospital, we want to have an equitable partnership. What does it mean? There are two types of thinking. You put my strength, you put your strength, and I put my strength into the field so that both of us will get benefited. There is no point in doing things which we don't know or which we can't do. Now tell me, what is the strength of Sipaka? I have explained before that we have already created a system of practice of standardization with the manpower, care, daily operations, quality improvement, of course, medical legal issues. To do all these things, we need an internal software, ICU software, that one. Yes, digital marketing, branding, and business development. These are the areas we have already created our, what should I say, platform. If you remember, I told like pharma companies, they have standardization. Wherever you buy medicine, it is the same. Lab test, wherever you do, it is the same. Whatever the equipment you buy, for that equipment, it works the same. That is standardization. Similarly, in these areas, wherever Sipaka goes, there is standardization. We have already done. Now, what does the partner hospital have? Number one, to get ICU infrastructure and equipment, they don't need to worry about it because I told you already, many of the places, they already have partial ICUs. All you need is a list of things to get. So Sipaka will help you on that. So you can get the infrastructure done. Number two, non-clinical maintenance. Hospital already has people to like security, like housekeeping, like let us say the attenders, non-clinical things you already have. You have autoclave. You already have laundry. All these things hospital has already got. You don't need somebody to come and tell you how to do it. Hospital existing means there are already got they have already got minimum patients coming. Now you want to grow to the next level. That's what you want, right? Physical publicity. Hospital has already been there for some time. You must be having some boards in place, some hoardings, some name boards in place. So these are the things hospital will already have. If I give you guidance, if Sipaka, if we come and give you guidance on just streamlining these things, you can do this. But if I give guidance, will you get clinical manpower and get it done? ICU patient care, how difficult it is for you to do. So, what is difficult for you, we get it done. And what is already easy for you, we just give you inputs, you do it on your own. So, this is what is called an equitable partnership. Number two, I just want to give you a success story of of this partnership like this. What we have what we have done in a place called Srigonda, which is there in Maharashtra. I just want to give you some examples from this place through equitable partnership. What we have done. See, they have got the ICU infrastructure in place. We gave them basic ideas of how to set up because it's a taluk place. In 3 months' time, we managed almost all different types of patients, like patients with stroke, head injury, and then we have managed diabetes and cardiac failure, and my patients with thrombolyzed. We managed patients with asthma, COPD, anemia with heart failure, UGI bleed. We could manage the patient because it was a, not a very serious and a severe bleed, which did not require surgical intervention. We managed the patient. Otherwise, patient had to be referred out. We managed, AKE patients, and then we ventilated patients there, both NIV and invasive ventilation and oxygen support. And then finally, we also managed patients with, the poisoning and suicide attempts. Now, if you see, we had an average survival rate of 92%. Out of 32 patients we managed, we could discharge 31, one death. That makes us to, percentage as 96% for that patient. So when you take an average survival rate of 92%, you go and check the basic, the average survival rates from US based ICUs and NHS, UK based ICU. Even if you take PubMed, there you can see that the mortality rate is 33% in US based ICUs and 27% in UK based ICUs. We are not boasting that we are better than them. Certainly not. They manage very serious and sick patients, but we also, for our level, we also manage serious sick patients here. But all I'm saying is, when you manage people within the timeline, golden hour, you take them fast, you get them in fast, and then you manage them with processes and protocols with standardized, which are defined in international standards. You also can actually at a taluk level achieve such a survival rates. Average ICU readmission rate was, 0.02%. How do you get it? Normally when you take the US or UK based ICUs, your average readmission rates range from, you see, in USA, it has gone up to even 10%. In UK based ICUs, it was 5%. In this 3 months time, we had only one, the readmission. But after 6 months, our average calculation was 0.02%. So this average readmission means you have not discharged the patient properly. So patient has gone to the ward and came back within 24 hours time. That's what is called average readmission rate. Similarly, our average patient satisfaction rate was 81%. You take American and UK standards, they were rating between 70 to 80%. I want to draw your attention that, the UK and US, both the places, the ICU treatment is free. They don't spend money. NHS UK, it is completely free. And in US, it is covered by insurance. Whereas our people, they pay from their pockets. 80% of our patients, they pay from their pockets. Still, when they understand that you have given them the care within the reachability, within the affordability, and with whatever the resources that are available at their disposal, you could manage them like this, people will really feel happy about it. They express their gratitude openly, saying that yes, whatever said and done, you charged, of course, yes, but otherwise I would have to pay double, triple amount. And then they express their gratitude. You see here in family satisfaction with critical care in UK, you see family satisfaction scores were high with 80%. For 80%, what they are saying is very high. So when we operate ICUs on par with international standards, whatever the cases that you may manage here, yes, you don't have quaternary level ICUs, you don't have so many super specialists available around you. You can't manage them, but with the available resources, whatever the patients that you manage here without referring them out, you also can really get quality indicators in ICU on par with international standards. That is what the point I would like to drive at. You see, this place, when you put ICU in this place, okay, when it is there in the top list now. When you open the page, rural ICU care provider Sipaka expands to India, and then it is available in that place, um, in that place, over a period of time, when you started with that, on the day of inauguration, this was the news. And over a period of time, in 3 to 6 months' time, when you put the same thing, it is on the top. Naturally, it comes on the top. This is how, when you start working properly in all dimensions, this is what is called branding. When you provide services properly and then take the data and then share it properly, automatically the name will come on the top. Tomorrow, if today people go and search in the Google, this ICU is standing on the top of the list now. Of course, so much of publicity has gone into place. So that is how, when you take your equitable, what you have, you put, what we have, we put, and then start doing the service. That is how it goes. That is what is called equitable partnership. Now, let us look at what is sustainable development. When you talk about ICU, it is like, when Sipaka puts an ICU in a hospital, it is like sowing a seed. It takes time. As far as financials are concerned, it takes time. I spoke about clinical output. I spoke about reputation output already. Within few months, you can actually produce clinical and reputation outputs. Now let us look at the financial outputs, how it goes. Okay, how you share with people. Now, as I told you, the branding and the development, it is like a tree, a plant growing and becoming a tree. It takes time, isn't it? It grows slowly and there won't be any initial returns, and you have to keep on nurturing it, and it takes a long time, but once established, it's a long lasting. It will actually feed you. You have been giving it manure and water. Tomorrow it gives you everything. It gives you fruits, it gives you shade, it gives you wood, everything, sustenance, everything it gives you.